Good afternoon to everyone. Welcome to our live webinar. It's 5 o'clock in Europe and 11 o'clock on the East Coast of the US, and we are getting started on time. Today's webinar is called Modeling Liver Disease from Acute and Chronic Injury to Hepatocellular Carcinoma for Development of New Treatments. First, I'd like to address a few practical matters. We are recording the webinar and the presentation will be available to all attendees afterwards. Then, after the presentation, our presenter will answer a few of your questions. So if you have any, please type them in the chat panel. We will gather all the questions at the end of our presentation and Samira will answer them to you. Also, if you are experiencing technical difficulties, please directly let us know in the chat and we will do our best to help you out. Now, let me introduce you to our speaker, Dr. Samira Ben-Hamouche-Trouillet. Samira Ben-Hamouche-Trouillet is a study director at Oncodesign in the Department of In Vivo Pharmacology. She received a PhD in 2008 in biochemistry, cellular and molecular biology. Then, for her postdoctoral training, she joined the Massachusetts General Hospital Cancer Center, Harvard Medical School in Boston, USA, to study the role of hepatic progenitor cells in cancer and mechanism of biliary cells polarization and lumen formation during liver development. She was then a group leader and assistant professor at Bordeaux University and Center Hepatobiliaire in the Paris area, where she worked on signal transduction pathway involved in lipid and glucose metabolism, NASH pathogenesis, and liver regeneration. In September 2018, Samira joined Oncodesign, where she develops preclinical model for liver disease, and she manages proof of concept study in inflammatory disease and in oncology. Before we get started, we have prepared a series of polls. I'm launching the very first questions. I invite you all the attendees to take a second to answer our poll. So the first question is, what do you expect by attending this live webinar? I let you a couple of seconds to answer. We look forward to your answer. All right, then I will close the first poll question and we will get started. Samira, are you ready?
Yes, I am.
All right, so I let you the floor.
Okay, thank you, Krista, and good afternoon, everyone. Thank you for being connected to this webinar. So today I will present you about liver disease and mouse preclinical models, which represent a fundamental tool to further elucidate the pathophysiology of liver disease and define effective treatments and potential biomarkers. So what is the liver? The liver is one of the largest and most functionally diverse organs in the human body. It sits in your abdomen on the upper right part under the ribs where it is protected locally. So everything that enters into your digestive tract will go into the portal vein to the liver, where it will perform very important function. So like glucose and lipid metabolism to produce and store energy, detoxification of medication byproducts, bile production to regulate, to help digestion, protein synthesis, and other substances that regulate blood clotting. And finally, it is very important to protect your body from bacterial and virus infections. So a healthy liver has the amazing capability to grow back and regenerate, and when it is damaged, and anything that keeps your liver from doing its job or from going back after injury may put the liver at risk. So as the liver performs such critical functions, liver disease results in anything that damages the liver over time, and almost anything that is toxic to the liver can cause damage. So when applied repeatedly, this will result to chronic liver disease, leading to scarring and cirrhosis. So typically what we call hepatitis is the inflammation of the liver that is caused by cell damage. So different etiologies have been described, like viral hepatitis, alcohol, autoimmune disorders, metabolic diseases like hemochromatosis or Wilson disease, and more recently, the non-alcoholic fatty liver disease. So any of these conditions causing cell damage and chronic inflammation may lead to fibrosis, cirrhosis, and eventually to cancer. So fibrosis is characterized by matrix deposition and angiogenesis that will lead to a disrupted architecture, a loss of the function of the liver, and an aberrant hepatocyte regeneration. And among cirrhosis complications, we find portal hypertension, cirrhosis decompensation, liver failure, and carcinogenesis. So regarding the clinical management of liver disease, the treatment of the underlying cause remains the primary response, so including virus suppression, alcohol abstinence, removing iron or copper, immunosuppression, and dietary change and exercise. So when chronic liver disease reach when chronic liver disease reach late stage of cirrhosis and cancer, transplantation remains the only effective therapeutic option. So, however, a broad area of new therapeutic has emerged and has been proposed to negatively impact the progression of chronic liver disease. And those strategies involve hepatoprotectants, anti-inflammatory drugs, anti-fibrosis drugs, drugs that promote fibrosis resolution, immunotherapy, etc. So animal models are excellent tools for testing new therapeutic options. And in this presentation, I will present you some of these models for acute liver injury, chronic liver injury, and for liver cancer models. So I think, Krista, it's time for the poll.
Yes, thank you, Samira. So I'm launching the second poll questions that we have prepared, and the question is the following. What kind of liver pathologies are you working on? I'll leave it open for a couple of seconds, and we look forward to your answers.
Ça va, je vais pas trop. Je vais pas.
All right, I'm closing now the poll questions, and I'll leave the floor to Samira again.
So thank you, Krista. So acute liver injury in mice can be induced by several hepatotoxics, and the most used are the acetaminophen, the carbon tetrachloride or CCl4, and the apoptosis agonist Fas ligand. So acute liver injury is a syndrome of severe and abrupt hepatocyte injury and inflammation that can lead to liver failure with a lethal outcome of in 30% of cases. The principal causes are the overdose of paracetamol, ischemia, drug-induced liver injury like antibiotics or cancer chemotherapy, viral infections, etc. So in clinic, acute liver failure is characterized by a widespread hepatic necrosis and apoptosis that will lead to elevated liver injury markers, transaminases, jaundice, encephalopathy, and a decrease of the liver weight. So the only therapeutic option for the overdose of acetaminophen patients is N-acetylcysteines, but it presents adverse effects and a narrow therapeutic window. So, sorry, as acetaminophen overdose is the principal cause of acute liver injury, the pathogenesis has been well studied in mouse models. In case of overdose, the conjugation system becomes saturated and leading to the accumulation of the NAPK toxic metabolites that will damage mitochondria and deplete both cytosolic and mitochondrial GSH, and thus leading to an increased oxidative stress, ER stress, the release of DAMs, an increased DNA damage, and the death of the hepatocytes. And this cell damage will in turn triggers the activation of the resident Kupffer macrophages and the massive recruitment of inflammatory monocytes via the CCL2 MCP1 chemokine. These cells promote the progression of the inflammatory mediated hepatic damage by secretion of pro-inflammatory cytokines such as TNF-alpha, IL-1 beta, and IL-18. Other cells like neutrophils and NK cells have also been involved in the acetaminophen liver injury. So phagocytosis of the DEL cells will initiate the resolution of inflammation and tissue restoration with the switch from the lysi-high macrophages, pro-inflammatory, to a lysi-low macrophage that exhibit a restorative phenotype, and which, along with Kupffer cells, produce anti-inflammatory cytokines like IL-10 and the release of growth factor like HDF and Wnt factors that will stimulate hepatocyte regeneration. Treg cells have also been involved in hepatoprotection and tissue repair. So in mice, the acetaminophen overdose can be recapitulated with the different phases of acute liver injury, including the hepatocyte damage and inflammation, the perpetuation of the liver injury and the death of the hepatocytes, and the resolution phase that is starting about 48 hours post acetaminophen challenge. And as you can see here, we do observe an induction of the liver injury markers, transaminases, as well as the LDH level in the sera of the mice, and an induction of the pro-inflammatory cytokines and chemokines upon the acetaminophen challenge. The histology of the liver here shows that acetaminophen induce a necrosis around the central lobular vein and an immune cell recruitment as seen here with the blue cells, with the blue nuclei of the immune cells, and that progressed to about 30% of necrotic area at 24 hours post-injury. So in turn, the tunnel staining allows the visualization of dying cells peaking at 8 hours post-acetaminophen injury. So depending on the pathology of interest or the targeted mechanism of action of interest, other models are available that will present some differential characteristics on the type of liver injury damages and consequently on the type of inflammatory and immunological response. So for example, in a simplified view, acetaminophen or CCL4 leads to necrosis and necroptosis and releasing high DAMPs and high inflammation that will target Kupffer cells, monocytes, and neutrophils, while the FAS agonist, the apoptosis agonist FAS ligand will represent more a model of fulminant hepatitis and liver failure through apoptosis, and target is more mimicking a target from the NK cells. So in terms of study design, they are quite, those models are acute and so quite short and can be used in a prophylactic and a therapeutical approach. And the first two models, acetaminophen and CCL4, are also good tools to study the resolution of the inflammation and the liver regeneration. So in contrast, repetitive damage, tissue damage will induce chronic liver injury that will result in an impaired regenerative capacity and chronic wound healing response called fibrosis. And several preclinical models of fibrosis are available, and I will present you today the CCL4 classical fibrosis model and two models of NASH fibrosis model. So chronic liver disease represents a major concern for public health, with 800 million people affected in the world. Liver fibrosis and cirrhosis are the end stages of most of the chronic liver disease. And so, as said earlier, it is characterized by a long-standing history of chronic parenchymal injury, persistent activation of inflammatory cells, inflammatory response, and a sustained activation of liver fibrogenesis and wound healing response. And this wound healing response is, of course, characterized by scar formation due to increased production and deposition of ECM proteins. And this is visualized, for example, here using the Sirius red or the trichromason Mason staining that is staining for the collagen fibers. And this will lead to impaired liver functions, tissue contractility, and an altered blood flow. So at the cellular and molecular level, the activated hepatic stellate cells into myofibroblasts are the major source of ECM proteins, collagen synthesis and deposition. So HSCs are activated by different mediators like chemokines and cytokines like TGF-beta, PDGF, VEGF, FGF, released by the resident Kupffer macrophages, infiltrating monocytes, but also leukocytes and other cells like the endothelial cells, the biliary cells, and the damaged hepatocytes themselves. Activated hepatic stellate cells are expressing alpha-smooth muscle actin or alpha SMA, and TGF beta signaling is a major signal transducer in this process. So CCL4 is one of the most commonly used hepatotoxic agents for the induction of liver fibrosis. It directly impairs hepatocytes by altering the permeability of the plasma and the lysosomal and the mitochondrial membranes. And so when administered repeatedly, it will cause severe centrolobular necrosis and repeated rounds of wound healing, and an imbalance between ECM production and degradation. And in this experiment, fibrosis is visualized using Sirius red staining, which stains for the collagen fibers. So 6 weeks after the start of the challenge, and this is quantified here. And the use of a potent TGF-beta signaling inhibitor targeting downstream effector ALK5 leads to a significant reduction of the fibrosis. and the matrix deposition. At the molecular level, CCL4-induced fibrosis is accompanied by an increase of the expression of genes encoding for collagen, alpha-SMA, tissue inhibitor of matrix metalloproteases TIMs, and the MMPs. And conversely, the treatment with the ALK5 inhibitor leads to a decreased induction of these genes and an increased expression of the MMP12, promoting matrix degradation in the prophylactic arm. So, as said in the introduction, non-alcoholic fatty liver disease have become one of the main causes of chronic liver disease in Western countries, and two models of NASH have been developed at Oncodesign. So, non-alcoholic fatty liver disease represents a spectrum of chronic liver disease ranging from simple steatosis to steatohepatitis, and that can progress to cancer. Non-alcoholic fatty liver disease are strongly associated with metabolic syndrome and with an estimated prevalence in the global population of 24%. Among the risk factors leading to steatosis and lobular inflammation, we find dyslipidemia, high fructose and high glucose diet, free fatty acids, gut-derived metabolic products, and so on. So during the NAFLD to NASH transition, there is an augmentation of the intrahepatic lymphocyte population, of the infiltrating inflammatory macrophages that will lead to necroinflammation, and so on. And so depending on the treatment responses and the lifestyle changes, the disease states are to some degree reversible. When advanced fibrosis or cirrhosis are not reached. However, in turn, in case of advanced fibrosis, the chronic hepatocyte cell death and the compensatory proliferation contribute to the increased risk for hepatocellular carcinomas. So the market for NASH drugs is currently estimated to reach at least 25 billion by 2025. The current frontline consists in lifestyle modifications such as diet and exercise. And here is shown a partial list of agents with a primary mechanism of action targeting the specific nodes that are involved in the development of the progressive NASH. So, and among them, we find the efficacy agonist obeticholic acid that showed some NASH improvement without worsening of fibrosis in current clinical trial. It is also important to stress that NASH is a very complex disease, which may make it difficult to treat with a single drug and may rather require combination therapy. So the first model that I will present you is a model of NASH fibrosis developed by combining repetitive injection of CCL4 together with a feeding with cafeteria diet, including high fat, high cholesterol, and high fructose diet. So in this model, we observe a strong accumulation of lipid droplets in the hepatocytes, inducing cell stress and damage, as measured here with the induction of the liver injury markers transaminases and the expression of the SHOP-ER stress marker. This will lead to inflammation, with the recruitment of inflammatory cells, as seen here in this liver section, and with the induction of the MCP1 CCL2 marker. And the use here of efficacy agonist obeticholic acid protects from steatosis and inflammation. Similarly, the fibrogenic response is observed here using Sirius red. And again, and the induction, of course, of the ECM-related genes. And again, obeticholic acid leads to a significant reduction of the fibrosis extent. We have developed another model of NASH that can recapitulate progressively the different steps of NASH pathogenesis to the development of hepatocellular carcinoma. In this model, a single dose of streptozotocin into newborn mice with a feeding with a high-fat diet from 4 weeks of age leads to steatosis, inflammation and NASH, fibrosis, and hepatocellular carcinomas within 16 weeks of age. Of importance, in this model, the metabolic syndrome is well recapitulated. Mice display a higher body weight gain, hyperglycemia, hypercholesterolemia, an impaired liver function, and an increased liver weight to body weight ratio due to steatosis, as measured here by the increase of the liver triglycerides. NASH can be measured using histology and semi-quantitative scoring of 3 main features: steatosis, ballooning, and inflammation. Fibrosis is also scored, showing progressive perisinusoidal fibrosis in pericentral and then in periportal towards a bridging fibrosis. At the molecular level, we observe also the upregulation in the liver of genes involved in inflammatory and fibrotic processes. So in summary, as for preclinical model of chronic liver disease and fibrosis, CCL4 model present the advantage of presenting a severe fibrosis even with a site and portal hypertension when it is longer. However, animal tolerability to CCL4 varies and need an increase in number of animals. If you need severe fibrosis in a context of steatosis, adding cafeteria diet presents this advantage of being really fast and robust in a context of steatotic, ballooned hepatocyte, and a high inflammation. In parallel, the NASH-HCC model here present another advantage. It recapitulates the full sequence of NAFLD from metabolic syndrome, the progressive development of steatosis to NASH, to fibrosis and to cancer, owing to delineate precisely mechanisms of action within the intricate nodes. So finally, another complication of the liver disease is the development of liver cancer, and particularly hepatocellular carcinomas. And here again, we can help you with providing orthotopic liver cancer models. So hepatocellular carcinomas is a major cause of cancer-related death. Its mortality has increased in Western countries, with a minority of patients diagnosed at early stage. Only the multikinase inhibitor sorafenib is available for the management of advanced cases. Based on genomic and signaling pathways profiling, 2 classes of HCC have been proposed. One proliferative class, which is mainly associated with HBV infection, high alpha fetoprotein, and a poor prognosis, and a non-proliferative class that is mainly associated with HCV and alcohol, low alpha fetoprotein, and a better outcome. So as for cancer model, the NASH-HCC model that I just described progress into HCC development as early as 16 weeks and reproducing very well the molecular and the histological heterogeneity as shown in a recent publication from Michael Karin's lab. This model allows for a pretty wide therapeutic window of 4 to 8 weeks and for longitudinal studies. We also have developed another model using orthotopic engraftment of mouse HEPA-1/6 derived tumor cells. So in this model, HEPA-1/6 invade about 80 to 90% of the liver mass, leading to a significant increase of liver weight to body weight ratio from 5 to 25% in the HEPA-1/6 engrafted mice. Other readouts have been set up to assess the tumoral growth, like MRI imaging, alpha-fetoprotein levels in the serum, and histological analysis with the alpha-fetoprotein immunohistochemistry. This model can be used for assessing immunological response, and here we show that about 40% of the mice respond to an anti-PD-1, as shown here with the decrease of the liver weight to body weight ratio and the decrease of the expression of alpha-fetoprotein and EpCAM markers of HEPA-1/6 cells. Finally, in the context of the IMODI consortium program initiated by Oncodesign, several PDXs, both hepatocellular and cholangiocellular carcinomas, are available and that are representative of the different etiology of liver cancer. Histological and genomic data are available on demand for some of them. Here's an example of an HCC PDX that has been engrafted orthotopically, and the tumor growth was assessed using MRI imaging. And we have shown that this tumor responds pretty well to sorafenib and gemcitabine, but not to gefitinib. So to summarize, this orthotopic model of liver cancer presents several complementary features that will help you to address the anti-tumor effect of preclinical compounds. The NASH-HCC model presents tumors that are representative of the tumor diversity observed in humans. This model takes more time to develop but presents a wide therapeutic window. Conversely, the HEPA-1/6 derived tumors are representative of the very aggressive form of HCC with high alpha-fetoprotein and with a narrow therapeutic window. And as used in immunocompetent mice, both models can be used for assessing immune-based therapies. As for PDX models, they present the advantage of being human-derived and study human-specific mechanism of action. And this model have been developed in immunodeficient mice, but humanized models can also be used. The therapeutic window is rather wide in this model. So I think, Krista, it's time for the next poll, I guess.
Yeah, correct. So our next poll question is about our oncology model, and the question is, which cancer model are you most interested in? The NASH-HCC model, the HEPA-1/6 orthotopic model, or the PDX models? And I let it open for a couple of seconds. Again, looking forward to your answers. Alrighty then, closing the poll question and back to Samira's presentation.
Okay, thank you, Krista. So I actually will conclude. So in summary, I have presented you preclinical models that recapitulate important features of human liver disease in part or entirely. This model can be used for therapeutic or preventive assessments of drug compounds and for elucidating mechanisms of actions. Several endpoints have been developed, including biochemistry parameters analysis, metabolic parameters, histology, biomarkers, expression, and so on. And we will continue to provide further characterization and improvements of these models, like the pharmacological validation of combined elafibranor and obeticholic acid in the NASH models, and lenvatinib and anti-PD-1 for the cancer models, the characterization of the immune cell population in the different models, and other kind of characterization. So thank you for your attention, and I will be happy to take questions. Thank you very much.
All right, thank you so much, Samira, for your presentation. We'll launch a very last poll question right now. So this is the question: what makes you choose us among other CROs? I let it run for a couple of seconds, and we will also be very happy to open a Q&A session. So you feel free to use the chat or the questions to write down your questions, and we will take a moment with Samira to answer them. Couple of more seconds for the poll. Alrighty then, so I'm closing it. I see at least a couple of first questions coming up. Samira, you ready for me?
Yes, yes, I am.
All right. So the first questions that I received is the following. Do you have a model reproducing human alcohol-related disease?
Okay, so no, we don't have, but of course, we can develop them. So they exist, of course, and they are often characterized with a mild hepatic damage, mainly due to high metabolic rate of the alcohol, actually the natural aversion to alcohol of the rodents, the absence of any addictive behavior, and actually a spontaneous reduction of alcohol intake. But they do exist. There are many. There is one of the models that is very with a high reproducibility is the acute on chronic ethanol. So we gave ethanol to mice, and before analysis we add an acute dose of alcohol. There are also others with liber decarli diet or liber decarli with a second hit when we add LPS or CCL4. So we have not developed any of them here in-house, but this is something we could do.
All right. Thank you, Samira. So we can develop it at Oncodesign. Next question. Just a second. All right, then there's another question here. Is there any model of cholestasis?
Okay, so so models of cholestasis indeed exist. So one of them is the BDL model, so the bile duct ligation model. So which is induced surgically and will lead to the accumulation of bile in the hepatocytes, and so the chronic damage. And actually it is characterized by a very strong fibrosis, but it has the problems of the surgical complications sometimes. Another model of cholestasis that can exist is the DDC model, which resemble more or less to the primary sclerosing cholangitis, and it is quite easier to perform. Another model that I know has been done by the team here is the ANIT-induced cholestasis that will actually damage the biliary cells themselves and lead to cholestasis and to fibrosis as well.
Thank you, Samira. I don't see any more questions coming up at this time. Do not hesitate. You're also very welcome to send us your questions if you have some coming up later. I think, Samira, we can close if we have no more questions coming up. So the webinar has been recorded, and it will be, a link to it will be sent to you tomorrow. If you have further questions, do not hesitate to send us email, and we will be very happy to answer them. And I think that's it. Thank you very much, Samira. That was great.
Okay.
Thank you for your time and for the
Thank
time
you
for the
very much.
questions.
Okay. Thank you all for your attention.
All right. So thank you very much, and we hope you enjoyed. And we wish you a great end of the day for those who are almost toward the end. Thank you, Samira. Bye bye, everyone.
Thank you. Bye bye, everyone.